Hey everyone, welcome to House Healthcare. It's Thursday, January 18th. And we are taking up a new bill today, H 766, an act relating to prior authorization and a whole lot of other stuff. And we have legislative counsel here today that will walk us through the bill and then also provide, and I don't know what order you're going to do it, but kind of how did we get here? We've done some work in this committee with prior authorizations over the last couple sessions and probably before that. So, and then we'll start hearing from witnesses. So, Jen, I'm going to turn it over to you.
Hey, good morning, Jennifer Carby, Legislative Counsel. I think it's really up to the committee whether you want to look at some of the things you've done previously or if it makes sense to walk through the bill first.
Why don't we do the history?
Okay, and I won't go too deeply into the weeds, but I've provided a document if people want to. So we went through and put together put in some language from fairly recent prior authorization legislation, enacted legislation, and the reports that came out of them. And so the first one, and I will say I did not include everything in here in the substance use disorder treatment realm. There has been some separate provisions relating to prior authorization in substance use disorder treatment, but they seemed less related to the prior authorization work that you're doing. But I did want to include this one because it's recent and because it gets at this gold carding idea. So in last year's Act 22, Section 8A directed the Department of Vermont Health Access to research the feasibility and costs of administering a gold card program for substance use disorder treatment in which the Agency of Human Services would not require a healthcare provider to obtain prior authorization for substance use disorder treatment if in the most recent 6-month evaluation period, the agency has approved or would have approved not less than 90% of the prior authorization requests submitted by the provider for the medication. And it had the department's research required to be submitted to the department's own Drug Utilization Review Board and Clinical Utilization Review Board by December 1st for review, consideration, and the provision recommendations. And then by April 1st of this year, so upcoming, the Drug Utilization Review Board and Clinical Utilization Review Board are each supposed to submit their recommendations to the Human Services Committee and the Committee on Health and Welfare, but this committee may be interested as well. So just flagging that one for you as something else that is going on. There was language enacted in 2 different bills or 2 different acts in 2022, Act 183, which was the big economic development bill that also had healthcare workforce development provisions in it. And in your own Act 167, which came from this committee, directing the Department of Financial Regulation to explore the feasibility of requiring health insurers and their prior authorization vendors to access clinical data from the Vermont Health Information Exchange whenever possible to support prior authorization requests in situations when they cannot automatically approve the request. It would have had the department direct health insurers to provide prior authorization information to the department in a format the department requires so that the department could analyze the opportunities for aligning and streamlining prior authorization requests. And there was a report due, and you can see a link here to that report that DFR submitted. Then there were several provisions in an act from 2020 relating to prior authorizations, kind of coming at it from a variety of different perspectives. So the first is a section that we'll actually be looking at a little bit today, 18 VSA 9418B. So this was codified. There is an existing statute on prior authorization in the health insurance context. This was adding a new provision to that requires health plans to review the list of the procedures and tests for which they require prior authorization at least annually and eliminate the prior authorization requirements for those procedures and tests for which the requirement is no longer justified or for which they routinely approve the requests with such frequency that it demonstrates that the prior authorization requirement does not promote healthcare quality or reduce healthcare spending to a degree sufficient to justify the administrative costs to the plan. And it requires each health plan to attest to the Department of Financial Regulation and the Green Mountain Care Board annually by September 15th that it has completed the review and appropriate elimination of prior authorization requirements. So that was enacted. Section 9 directed the Department of Financial Regulation in consultation with others to report on opportunities to increase the use of real-time decision support tools embedded in electronic health records to complete prior authorization requests for imaging and for pharmacy services, including options that minimize cost for both the providers and insurers. And there's a link to that report. Section 10 of the same act had the Green Mountain Care Board in consultation with DVHA, ACOs, payers participating in the ACO model, healthcare providers, and others evaluate opportunities for and obstacles to aligning and reducing prior authorization requirements under the all-payer model as an incentive to increase scale, as well as potential opportunities to waive additional Medicare administrative requirements in the future. And a report was due in January of 2022, and there's a link to that report. Section 11 directed health insurers with more than 1,000 covered lives in the state for major medical health insurance to implement a pilot program by January 15th of 2022 that automatically exempts from or streamlines certain prior authorization requirements for a subset of participating healthcare providers, some of whom must be primary care providers. It required insurers to make available electronically, including on a public website, details about its prior authorization exemption or streamlining program, including which medical procedures or tests would be part of the program for providers who qualify, the criteria for providers to qualify, the number of providers eligible for the program, including their specialties and the percentage who are primary care providers, and who to contact for questions about the program or determining eligibility for the program. And it required insurers to report on their programs to this committee and other committees and the Green Mountain Care Board with the results of the program, prospects for the insurer continuing or expanding the program, feedback the insurer received about the program from healthcare providers, and an assessment of the administrative costs to the insurer of administering and implementing the prior authorization requirements. I found Blue Cross Blue Shield's report on the legislative website, so that's what I posted here. There may be others as well. Finally, Section 12 directed the Department of Vermont Health Access by September 30th of 2021 to provide findings and recommendations to this committee, other committees, and the Green Mountain Care Board about prior authorization requirements in the Medicaid program, including a description and evaluation of the outcomes of the prior authorization waiver pilot for Medicaid beneficiaries attributed to the Vermont Medicaid Next Generation ACO model, certain information for each service for which Medicaid requires prior authorization, so the denial rate for the prior authorization requests and the potential for harm if there was no prior authorization requirement. Based on that information, the services for which DVHA would consider waiving prior authorization and exempting gold carding healthcare providers whose prior authorization requests are routinely granted. The results of DVHA's current efforts to engage with providers and Medicaid beneficiaries to find out the burdens and consequences of Medicaid's prior authorization requirements and their recommendations for changes. The potential to implement systems that would streamline prior authorization processes for the services for which it's appropriate, with a focus on reducing burdens on providers, patients, and DVHA. Which state and federal approvals would be needed in order to make changes to the Medicaid prior authorization requirements, and the potential for aligning prior authorization requirements across payers. And DVHA's report on that is also available on the legislative website.
So we've done a lot for the years, and we still are here because there's this, there's still an issue, right? We still hear it from all of our own providers. We hear it from constituents that there is an issue with prior authorizations. So you'll see the interest in the room for this bill, and we're going to walk through it. We'll get to questions. We'll walk through it and see if we can finally get to a point where we can do something that will help with the prior auth situation. Leslie?
So I'm just curious to know, how do we know these things, the reports that came for the first time have been implemented, what changes have been made on the basis of all this of the same?
So we've had testimony over the last couple of years on these various reports.
Okay.
So this was just a reminder as to what we've done, which is hard to remember sitting in these seats and everything that we're doing. So,
Okay.
but yes, we've had testimony on this stuff.
Okay, and it's all been implemented.
All the reports have been provided, some stuff has been implemented, some of it's working, some of it's not working. I think we'll hear that today as we go through that.
Thank you. Yeah.
Could we get a run, maybe we will get a run through, a few examples of prior authorization.
Yes, we have provided.
There's so many things, and I just want to know what it is or what the problem is.
Yep, we'll hear from providers today. All right, let's go through the walkthrough. If there's no more questions.
All right. So we will now be looking at H 766, which is introduced by Representative Black as the lead sponsor, but I believe all members of this committee are sponsors. Yes, Black and Houghton, but the rest of the committee is also the sponsors. So the name of this bill is an act relating to prior authorization and step therapy requirements, health insurance claims, provider contracts, and collection of cost sharing amounts. So we're going to go through a few different topics. The bill is arranged in numerical order by title number. So we start in Title 8 and move our way into Title 18. For the first section, Section 1, we're amending 8 VSA Section 4089I, which is about prescription drug coverage in major medical health insurance plans. And so we're looking particularly at step therapy. Step therapy is just in general concept where a plan requires an insured individual to go through a certain order of tried prescription drugs in a certain order, sort of steps. So you don't jump right to the most expensive drug. For example, you might start with different drugs, trying those out before getting to other drugs. There's a process in place. So under existing law, health insurance plans offered by a health insurer or pharmacy benefit manager on behalf of the health insurer that provide coverage for prescription drugs and use step therapy protocols, under existing law, they cannot require failure, meaning it didn't work, on the same medication on more than one occasion for continuously enrolled members or subscribers. So we're making some tweaks to that. So with this language in the bill, it would say a plan that provides coverage for prescription drugs and uses step therapy shall not require failure, including discontinuation due to lack of efficacy or effectiveness, diminished effect, or an adverse event. Not require that on the same medication on more than one occasion for insureds who are continuously enrolled in a plan offered by the insurer or its pharmacy benefit manager. So that keeps this idea of continuously enrolled, but under existing law, it's a little unclear whether that's continuously enrolled in the same plan or just continuously covered by health insurance. So the plan cannot require failure on the same medication on more than one occasion for insureds who are continuously enrolled in that insurer's plan, and shall grant an exception to its step therapy protocols upon request of an insured or the insured's treating healthcare professional under the same time parameters as set forth for prior authorization requirements, which we're going to come to in a few sections, if any one or more of the following conditions apply. In this case, they would have to grant an exception to their regular step therapy protocol if one or more of the following conditions apply. If the prescription drug that is required under the step therapy protocol is contraindicated or will likely cause an adverse reaction or physical or mental harm to the insured, and this is any one or more. So if that is the case, or if the prescription drug required under the step therapy protocol is expected to be ineffective based on the insured's known clinical history, condition, and prescription drug regimen, what else they're taking. If the insured has already tried the prescription drugs on the protocol or other prescription drugs in the same pharmacologic class or with the same mechanism of action, which have been discontinued due to lack of efficacy or effectiveness, diminished effect, or an adverse event, regardless of whether the insured was covered at the time on a plan offered by the current insurer or pharmacy benefit manager. Or if the insured is stable on a prescription drug selected by the insured's treating healthcare professional for the medical condition under consideration, so they're already on a drug and it's working, or the step therapy protocol or a prescription drug required under the protocol is not in the patient's best interests because it will pose a barrier to adherence. So they're unlikely to keep up with the prescription drug regimen, or it is likely to worsen a comorbid condition, likely to make something else they have worse, or it's likely to decrease the insured's ability to achieve or maintain reasonable functional ability. Like it's going to make them really, really sleepy and their job is long distance truck driving. Somebody else in the room gave me that example, but
I was gonna say, that was good, right off the top of my head.
all right, so that list of things is the circumstances under which the insurer would have to grant an exception to its step therapy protocols, if any one of those situations was in place. And then the only other change in this section is really just some cleanup of existing language that talks about specific instances of not having to use step therapy for prescription for the treatment of substance use disorder. And I'm just putting in some provisions clarifying that notwithstanding any provision of subdivision 1 to the contrary. So that's section 1. I don't know if you want to just go through the whole thing and then discuss.
The
Okay.
whole thing, and then, I think a lot of things will make more sense once we start hearing testimony.
Okay. Great. And I know some of the terms are new, maybe new to people.
Yeah.
Section 2, now we're in Title 18 and we're in a subchapter we're in the chapter on health care administration, I think, 18 VSA chapter 221, and we're in a subchapter that deals a lot with kind of claims processing and the arrangements between the interactions between plans and providers. So one thing just to note before we jump into this is that we're starting here with 18 VSA section 9418A, but 18 VSA section 9418 has a bunch of definitions that apply for the whole subchapter. So if you're looking at terms like contracting entity, covered entity, those terms are defined. And we can look at those if that's helpful, but know that those are defined terms.
And just real quick, and so this section relates to the testimony we had last week about claims edits.
Yes, exactly. So this section, exactly that is going to be about claims edits. So under existing law, there is a requirement already that health plans and other payers accept and initiate the processing of all healthcare claims submitted by a provider pursuant to and consistent with various existing conventions and coding systems that I think you talked about some. I know Sebastian brought books, I think, visual aids, CPT,
They're up there.
HCPCS, et cetera.
Where'd they go?
Up there.
Oh, okay. There we go. So in subsection B, under existing law, there are some requirements when editing claims that health plans and other payers adhere to edit standards, except as provided in subsection C, which we'll look at. This makes some changes to that provision. So first of all, it says that the health plans and other payers, I'm just contracting the list, well, maybe we'll just say payers, adhere to the edit standards and also the processes and guidelines. And it specifies that they adhere to those adopted by NCCI, the National Correct Coding Institute, and not this longer list of other standards or other providers of standards. So when editing claims, payers would have to adhere to edit standards, processes, and guidelines adopted by NCCI. But in subsection C, adherence to the edit standards in subsection B, which would now just be those from NCCI, is not required, and under existing law, not required when necessary to comply with state or federal laws, rules, regulations, or coverage mandates, or for edits that the payer determines are more favorable than the edit standards in what would now just be subsection B, or to address new codes not yet incorporated by a payer's edit management software, as long as those edits are, we're going to add to this list, under existing law, as long as those edits are developed with input from the relevant Vermont provider community and national provider organizations. And clearly, so new language, clearly supported by nationally recognized standards, guidelines, or conventions, approved by the Commissioner of Financial Regulation, and available to providers on the plan's websites and in its newsletters. So A and D are existing law, B and C are new. Subsection D is new. This would prohibit health plans and other payers from releasing edits more than once per year, and would require that the annual round of edits not be implemented without prior review and approval by the Commissioner of Financial Regulation and at least 90 days advance notice to providers.
That's all new.
That is new. Yes, and we are on page 6 for anyone looking for work. Subsection E is also new. This would say the no health plan or other payer shall subject any healthcare provider to pre-payment review. And then it defines that term to mean any action by the health plan or other payer or by anyone acting on its behalf requiring a healthcare provider to provide medical record documentation in conjunction with or after submission of a claim for payment for healthcare services delivered, but before the claim has been adjudicated. So prepayment review, just to collapse that a little bit, would mean anything that health plan would do to require a provider to provide medical record documentation with their claim before the claim has been adjudicated, before the payer makes a decision on the claim. Then we've got some re-lettering happening. The next few sections.
Ask a question about that.
Sure.
So that means that there would be no situation in which a decision would be made about payment that would review the records, because like it sounds like it's saying like they would either pay or not without reviewing records, and then they would review the records if they needed to.
I'm going to defer to,
Yeah, why don't we
Others.
hold that until we have testimony?
Okay.
because I don't know what the current claim, enough about what the current
Okay.
claims process looks like to say what change that would make. All right. So then after re-lettering, we get to the top of page 8. And instead of saying every health plan, we start with if adding an edit. So if adding a new edit pursuant to subdivision C1 or C2, now effectively every, but a health plan or payer shall publish on its provider website and in its provider newsletter or equivalent electronic provider communications. So if adding a new edit, the health plan or payer has to publish or otherwise make available electronically certain information, some of which is already existing law. So the name of any commercially available claims editing software that it uses, the specify specific standard or standards that the entity uses for claims edits, and it would add and how those claim edits are supported by those specific standards. Existing law says the payment percentages for modifiers, and then instead of existing law that says any significant edits added to the claims software product after the effective date of this section, which is not helpful language, made at the request of the health plan, contracting entity, covered entity, or payer, it would say the specific edit or edits added to the claim software product. So if they are adding any specific edit or edits, they would need to include that information on their website or in their newsletter or equivalent electronic provider of communications. Then we have more relettering. And then finally, getting close to the end of this section, under existing law, and I remember drafting this, so it was me, but we directed, many years ago, we directed at the time, well, we didn't direct, we requested, because they are not state entities, we requested Blue Cross Blue Shield and the Vermont Medical Society to continue convening a working group they were already convening. In this case, the language would change to establish a working group comprising the health plans, contracting entities, covered entities, and payers subject to the reporting requirements in subsection 9414A-B of this title. That, just to pause, is an existing requirement, reporting requirement for insurers to report a bunch of information annually to DFR, and it applies to insurers with 2,000 or more covered lives in Vermont and any other plan that is offered through the exchange. So all of those health plans would be part of this working group. Representatives of hospitals and healthcare providers, representatives of DFR and of other relevant state agencies, and other interested parties. And instead of studying the edit standards and what's going on in some particular language, this would have them look at trends in coding and billing, so a little bit more broad scope that health plans and other payers, or a combination of them, are seeking to address through claim editing. And it's supposed to provide an annual progress report to this committee and the Committee on Health and Welfare and on Finance in the Senate. And then finally, we just have some more updates to subsection designations. So that was section 2 on claims edits. Section 3 gets us into prior authorization. This is, again, amending an existing statute on prior authorization. Under existing law, health plans are required to respond to completed prior authorization requests from healthcare providers within 48 hours after receipt for urgent requests and within 2 business days after receipt for non-urgent requests. And it requires health plans to notify healthcare providers or make available to them a receipt of the request for prior authorization and any needed missing information within 24 hours after receipt. All right, so we're about to unbundle these and do a few different things with them. So instead of that language, the bill would say, for urgent prior authorization requests, a health plan must approve, deny, or inform the insured or healthcare provider if any information is missing from a prior authorization request within 24 hours following receipt. So first thing this is doing is moving from 48 hours for urgent requests to 24 hours. If a health plan informs an insured or healthcare provider that more information is necessary for the plan to make a determination on the request, the plan will have 24 hours to approve or deny the request upon receipt of the necessary information. So that's for urgent, what it will look like for urgent prior authorization requests. For non-urgent prior authorization requests, we would keep this 2 business days. A health plan must approve or deny a completed prior authorization request from an insured or provider within 2 business days following receipt. But the plan must acknowledge receipt of the prior authorization request within 24 hours following receipt, which is similar to the existing law, and inform the insured or healthcare provider at that time if any information is missing that is needed for the plan to make a determination on the request. And similar to what we saw above, if the plan notifies an insured or provider that it needs more information, the plan will have 24 hours to approve or deny the request upon receipt of the necessary information. So the biggest change here is really moving from 48 hours to 24 hours for urgent prior authorization requests, but also making it a little more clear what happens if information is missing.
Is there a definition of urgent? I know
I
we've got,
think there is.
we've got a lot of definitions.
People on yes, did you have
Sebastian Arguego, DFR. The definition of urgent is addressed in Department Regulation 0903, and that definition is in the prior auth memo that I'll refer to in my testimony.
Okay, great, thanks.
Thank you. All right, under existing law and not changed here, but just I think important for understanding. If a health plan does not, within those time limits, respond to a completed prior authorization request, acknowledge receipt of the request or request missing information, the request will be deemed to have been granted. And that would not change. Then we've got some additional provisions on prior authorizations. This would say that prior authorization approval for a prescribed treatment, service, or course of medication shall be valid for the duration of the prescribed or ordered course of treatment or 1 year, whichever is longer. So somebody doesn't have to keep asking for continued prior authorization during their treatment or for 1 year. For an insured who is stable on a treatment, service, or course of medication as determined by their provider that was approved for coverage under a previous health plan, a health plan shall not restrict coverage of that treatment, service, or course of medication for at least 90 days upon the insured enrollment in the new plan. So this would give some time when somebody changes plans before they would have to get a new prior authorization. Section 4 is also about prior authorization, and we're still actually in the same statutory section, but treating this as a separate bill section. This is a new provision that would require the Department of Financial Regulation to adopt rules, bulletins, or other guidance that prohibits carriers from imposing prior authorization requirements for any generic medication or for any admission, item, service, treatment, procedure, or medication, or any category of them that have low variation across healthcare providers and denial rates of less than 10% across carriers. So this kind of creates a gold carding type program, but through rules, bulletins, or other guidance. And in developing its rules, bulletins, or other guidance, the department is allowed to rely on prior authorization data submitted by the health plans pursuant to subsection H of this section, which is insurer annual reporting on prior authorization, actually from one of those prior acts we looked at before we looked at the bill, and to section 9414A, that's that annual reporting by health insurers. And then it specifies legislative intent that the rules, bulletins, or other guidance that the department develops should be designed to apply to frequently used medications and services, especially those ordered by primary care providers, and to achieve consistency in prior authorization exemptions across health plans in order to meaningfully reduce the administrative burden on healthcare providers.
I'm going to stop you there, Jen. The rest, that's the end of the prior auth section,
That
right?
is the end of the prior auth section.
So we have so the rest is about, I'm going to call it direct billing, but I don't think that's what we call it in the bill. Can we, Jen, maybe jump to the effective dates on those sections that you read? And then we'll come back to the section. So we have a lot of people. How I'm going to do this to make it hopefully more understandable for all of us is we're going to break this bill up in sections and we're going to take testimony on the different sections. So today is mostly the prior auth piece. We have a lot of people to hear and we have some people who have time constraints. So if everyone's agreeable, we'll skip the walkthrough of the section we're not going to cover today, go to the effective dates, and then we'll start testimony. Does that work? Great.
All right. Great. So section 8 is the effective date section, and section 4 would take, and the effective date section would take effect on passage. Section 4 is the one we just looked at with DFR issuing rules, bulletins, or other guidance on a gold carding type or streamlining prior authorization requirements. With those rules, bulletins, or other guidance to be adopted on or before March 1st of 2025, and applicable to all health plans issued on and after January 1st, 2026. So even though section 4 would be effective on passage, it wouldn't actually be applicable until January 1st, 2026. The remaining sections would take effect on January 1st of 2025, so next January 1st, and would apply to all health plans issued on and after that date, to all healthcare provider contracts entered into or renewed on or after that date, and to all claims processed on and after that date.
Any questions for Jen on the sections we reviewed? So Brian, if you can remember the question you asked, because that is
I wrote it down.
Okay, because that's not going to be today.
I wrote all my questions down so I wouldn't interrupt.
Okay, great. All right, thank you, Jen. All right, so we are going to jump around a bit because I have listed here, thankfully, our committee assistant who has to be where when. So we're going to start with Dr. Trey Dotson, who's Chief Medical Officer of Southwestern Vermont Medical Center. Great. Welcome.
Thank you. Thanks. Good to be here. So a couple of things in healthcare, when we communicate, we try to do it streamlined. We use something called SBAR, situation, background, assessment, and recommendation. So I will do that today. It'll help frame my comments. Situation is that the prior authorization process is really out of control. But I'll give you a little background. I very much support the intent of prior authorization. I support reducing utilization to things that add value. And I have seen examples of studies, medications, treatments that really were outside of guidelines, were not being, not following standards. And there's got to be a process to limit those. But prior authorization, it really is out of control. Yesterday, I sent a note out when I learned I was going to come up here. Just to a few people, a couple people in our billing departments, a couple physicians, a couple staff members saying, hey, I'm going to be up here. Can you give me, your feedback on this? Even though we do talk about it a lot. And I couldn't believe the number of emails I received. I received about 25. I sent it to 4 people. So it shows you. And people are frustrated. And, we can't make decisions just based on frustration. There's a lot of frustrations in the world. And, some of those frustrations are due to things that need to be in place. But the whole prior authorization has to be revamped. So some of the examples they gave me, by the way, I'm not an expert on prior authorization. I am an expert on taking care of patients. And again, I support following guidelines, making sure I'm following guidelines, making sure my colleagues are, so that we are doing the best for our patients, reducing costs and, improving treatment outcomes. So they gave me, several examples, and you have to think about them, but many of them are addressed in this bill, which is why I support the bill. One was, this family medicine physician said, look, there are no neurologists in our area. So she has really developed her skills, taken extra training to treat things like migraines that, she might have treated in the past, but when they get to a certain point, you send them to a neurologist. And so she has a few patients that every month she has to go through the entire prior authorization process, which, by the way, she really doesn't have to do that much. Her staff do in a very small office to get the same medication approved, to give it to the same patient who's receiving benefit. It'd be different if every year you needed to check. It's not like she doesn't check with the patient and make sure it's still the right treatment each time. And that's just an example. She's like, what a waste of my staff members' time. When I talk to the staff members, they say the intent, they understand the variability between the different payers is pretty significant. Now, they deal with not only Vermont, they deal with other states, like many offices are going to be dealing with. And most of the things are online, but sometimes the online stuff doesn't work. They still have to make phone calls way too much of the time. And I got an email back from this one person who said, I'm currently on the phone. I've been on the phone for 22 minutes. I'm not even doing the prior auth. I'm trying to figure out whether or not the prior auth is required so I can start the process. And then while typing, she accidentally hit a button and it hung up the phone. So how did we do it? And that's a true story. She says sometimes it's 60 minutes. She recognizes, she's thinking about the outliers. But when we look at our workforce and the amount of people involved in doing that, it's pretty ridiculous. In the end, a couple of the doctors told me some things that I probably knew, but sort of ignored. They said, hey, look, in the end, I'm going to get this for the patient anyway. So it's a waste because I'm going to keep going through the process till I get the patient. Somebody told me, and they tell me this pretty regularly, I'm an emergency physician, so I'm a little immune in my physician role from prior auth. And so they send me the patient. So the other day I was working, low back pain, change in the person's ability to urinate. That's a concern for something emergent. They know it's going to take days to get it approved. So they send them to the emergency department. And you might say, well, isn't that the best location for the patient? Actually, no, not for this particular situation. It was not. Many of the times it is, but not in this situation. And so they're going to get the process done anyway for the patient. Let's see, I wrote down a few other things. I happen to be part of the Dartmouth Health System and Southwestern Vermont Medical Center, and finances are really tough. We have a lot of staff that we worry about all the time. And we have staff members, by the way, that their only job is to do this, which is kind of incredible. But I can't imagine if I was in in a smaller practice. Like we talk about the burdens on the smaller practice. It's for larger practices, hospital systems, but even smaller practices, getting on the phone and waiting, people leave the job. I mean, I can't stand doing it myself. I call the cable company. I can't get through the cable company. Let me just make sure I hit everything here. By the way, I can give any of these examples. I know they're anecdotal. I know these aren't real data driven. I can give the data there too. The lack of standardizations. Another physician told me, it's just a big game, right? And in fact, we have at least 3 staff members here that we wouldn't even really need, or we could put them in other places if we weren't playing this big game. So the intent is correct. Let's make utilization in a collaborative way appropriate. Let's reduce unnecessary utilization. But this is not working. It probably came out of some good ideas. So my recommendation specifically, I like this bill. I think it's starting off in the right direction, but we've got to just keep collaborating between the payers and the providers, actually, frankly, hopefully before it gets to this point, so that we can, do things that really improve the outcomes without going through the unnecessary costs.
So Art, I'm going to ask you, thank you. I'm going to ask you first if the examples he provided help answer your, what is a prior
It
authorization?
helps, but I'd like to hear. One of your examples was, you gave it to somebody and it took a long time. But just go through a simple thing as, the back pain. Okay, somebody has back pain,
Mhm.
and it doesn't have to be that case,
Yeah.
but what are the steps that need to be taken to get the prior authorization?
Sure. I'll actually give you one that occurred last night. Nothing to do with this. A friend.
Yeah.
So she had an ultrasound. She's 50. She had an ultrasound that showed a mass on her ovary.
Okay.
And I'm going to give you 2 from her perspective. So she was told by the physician that they're going to need to do a biopsy of type because it looked concerning, and ovarian cancer is very concerning. And so after a couple of weeks, this person's going through this. Now, the doctor's office probably should have called her and said, we're having problems. But she called and said, what's going on? I'm supposed to have this. And they said, well, unfortunately, we keep sending off for prior auth and it keeps getting rejected. And the idea was, is it being rejected because it's not needed? No, it's because it's so complicated to check the right boxes for the diagnosis that the doctor kept checking the wrong box. Now, is that doctor stupid? No, not at all. It's just too complicated. And it's so standard. Ovarian mass looks abnormal, needs that. What the staff were doing is the staff were getting on a website, so that's an improvement when they work, and entering, they have to be trained in this, which means, by the way, they need experience of like years or several months to be able to enter all the information correctly so that the payer will then see it. And then there's going to be up to 14 days with many to review it and approve it or not. So, in the end, again, what's going to happen? She is going to get this procedure. If they refused it, she probably would have somehow wound up in my ED and we would have somehow gotten it done. So all of this is just a big waste for that. That's the process. So the process is you have staff that enter on a website. They may have to make some phone calls. They enter a bunch of information and they wait and it comes back.
Okay.
And then in the end, when it gets denied, what happens is it goes to these multiple tiers. And then there's a medical director at the payer, and that medical director gets on the phone with the doctor and they talk through it.
So, and I'm sure we'll hear from the insurance company.
Yeah, and again, I'm
a simple guy, and I don't understand why something like that, you just don't say emergency care needed, check that box and it gets done.
Well,
That can happen. I mean,
I tell you what, I have to be transparent here. I support processes that make sure we're doing utilization right. And there are parts of the country where that stuff is not done.
Okay.
I'll be extreme there. Someone sprains their ankle and they immediately get an MRI, and that's just really not justified.
Okay.
It causes the cost to go up and it doesn't change the outcome.
Okay.
But all of these people, I mean, we can't act different just because we're in Vermont, but I can tell you that we have opportunities to improve utilization, but there are parts of the country where it's out of control.
So this is a tremendous burden on administration, on staff, and so forth and so on.
Yes.
That's what we're trying to with the bill eliminate. I know.
That's right.
And
we've talked about it.
And I just want to add, it's a tremendous frustration on the patient.
Mhm.
So someone who has a
That's what I'm
mass
saying.
on their ovary and they have to wait
Yeah.
weeks I mean,
You're worried for 2 weeks.
yeah, if anyone has a family member, which I'm sure we all have, who have had cancer, it is a tremendous burden, anxiety, stress, to wait for that. So, yeah. Mari, sorry, we have one committee member on screen, but she's actually like in the middle of the room, so you don't have to turn around. Go ahead, Mari.
Yeah, and I would just add, full disclosure to our witness, I'm a registered nurse, long time. Can you talk a little bit about delay of care and the significant problems that can cause, not just in this case, but many cases, delay of
Sure.
treatment, delay of care?
Yes. And again, I preface this by saying, data is really important. So a lot of these stories are anecdotal, but there's too many. It's hard to come up when you think about things like cancer, it's hard to find data that each day makes a big difference as far as the outcome. It does make a big difference. Every day of delay in cost, people out of work, childcare issues, certainly the anxiety, which anxiety plays into the placebo effect. If you feel uncertain about something, your outcome is likely to be worse. When we talk about orthopedic injuries, which you can probably relate to, and the need for more urgent, talking about the urgent versus who asked that urgent versus, there's definitely bone healing, situations that are hampered by delays in care. So delays in care are important for outcomes. Sometimes they're hard to show on paper, but the rest of it supports the rest of the concerns support that, waiting these delays, they add no benefit and it's going to happen anyway. It's very rare that I talk to someone and say, yeah, we couldn't get prior auth, so we just decided you don't have a problem. I mean, they just gonna, and I was thinking about this earlier. I have to be very careful because physicians and nurses and advanced practice providers, we are all very truthful people, but if a patient needs something, we're going to go to the extreme end. So if there's 4 boxes to check and one says the outcome's likely to be fine and the outcome's possibly going to be extreme, if the patient needs it, the outcome's possibly going to be extreme every single time. So it's just things put in place with good intent, but then they end up causing way too many inefficiencies.
Another question?
I just want to ask some really stupid question. How long did you go to medical school?
So medical school's 4 years.
Did you do a residency?
Yes, 4 years.
4 years? Any internships?
Well, that included the internship. Yeah.
Internship. How long have you been practicing?
19 years.
And you're a licensed physician?
Yes.
Thank you. Not a stupid question. That's established credibility.
Any other questions for the doctor? Thank you so much for coming up. We appreciate your time. Okay, so I think we can go to Sebastian. And I know you have a stop at 10:30.
Try and get through as much as I can. So Sebastian Ardwengo for the Department of Financial Regulation. And I think Representative Peterson asked a good question in what is a prior authorization? So I think that is where I will start in terms of explaining what is a prior authorization and how are they currently regulated under Vermont law. So I'm going to join the Zoom link so I can show you them.
Props today for you.
No, unfortunately not.
All right.
It would be time prohibitive to draw the whole timeline on the whiteboard. As much as I would love to do that for you.
You can't try the irony though.
Right.
That taking the time to map out prior authorization would delay you excessively.
Yeah.
Yeah.
Sorry.
Okay. So, as Jen Carter shared with you, we've done a lot of reports previously on prior authorization. And for the purposes of this presentation, I'm going to refer to our previous presentation under Act 183. So let's see if this works. Yes. Okay. So this is the prior auth process and all of our existing laws that regulate that process. So the portion of this that you will hear providers talk about, and with good reason, is this step right here, where they have to submit the paperwork to get that PA approved. But there are other steps in the process where Vermont law constrains how the process works. And I just want to go over some of those with you. So just at the outside, we have laws that limit when payers can require prior auths. So one good example is 18 VSA 4754, which prohibits prior auths for services related to medication-assisted treatment. Then we also require plans to review their PA requirements at least annually and eliminate ones that are no longer justified. Part of that statute is an attestation about how payers are going about reviewing all of their PA requirements. And beginning this year, we being the department and the Green Mountain Care Board have pretty substantially expanded that attestation. So we have a lot of great data on the different services for which payers added or removed PA requirements. And that's all in the memo that we shared with the committee. And it will also be posted to the Green Mountain Care Board's website. So then on the step that drives providers batty, where they have to submit paperwork, we, in addition to the online portals that all of the payers have, we also have a uniform form to standardize the PA process for non-pharmacy PAs between payers. And we just worked with the Department of Vermont Health Access, Blue Cross Blue Shield, Cigna, and the Healthcare Advocate over the last year to revamp the form. So if a provider wants, they can use that one form for all of the commercial payers and Vermont Medicaid.
But that's not a mandate.
No. And finally, in terms of the insurance company reviewing the request, at most for non-urgent PAs, payers have 2 business days to respond. So if the payer does not respond within 2 business days, let's say for a non-urgent PA request, then that request is deemed approved under Vermont law. And in our expanded attestation, we did ask all of the payers how often this happened. And MVP reported it was roughly 5% of the time. Blue Cross Blue Shield reported that it was roughly 0.5% of the time across all services. And then Cigna reported that this never happened for them, which is what they reported. So we'll see how those trends continue in future years.
May I ask, a response does not mean a final decision.
Yes.
A response could just be, we've denied, we need more information.
Yes.
So it doesn't mean that the situation is resolved after 2 days.
Yes.
Okay.
It just means that the payer has acknowledged the request and either approved it or said, we need more information. And finally,
Interrupt you real quick. Did they have to report how often they got it and responded with, we need further information? Was that part of their reporting?
that was not part of the attestation that we required. We do capture a little bit of that in the Act 152 reports in terms of administrative denials. And I shared a little bit of that with you last year, and I'll go over it again as a refresher.
Thanks.
So at the end of the process, if a PA is denied, then depending on the reason for the denial, like the payer saying that it's not medically necessary, the patient can then seek external review of the payer's determination. So I'll stop here and take any questions about the process or the laws that currently govern.
Art, and then Leslie.
Yeah, I'm thinking about Medicaid. Do they operate under different rules here, or all rules apply to them as well as everyone?
For the most part, yes. Medicaid is very much its own entity and operates under different rules than commercial health plans do.
Okay, but do they require less prior auth than the insurance companies?
I think that's gonna have, we'll bring Diva to the table.
Yeah, that's,
Join us too.
I can't answer any questions about.
Got your name. I blanked on your name when I asked the
We'll
question.
bring Diva.
All right,
Yeah.
that's fine. Thank you.
Leslie.
So I'm just wondering, after the first 2 days, and there's a response, what happens after that? If there's a denial, are there any requirements to respond again, or can it be just left in limbo forever? How does that work?
Yeah, so if a claim is denied, if a prior auth is denied, then there's no need for a further response. But the patient then has a right to appeal that decision at first within the insurer, but then they can externally review it through the department. And what that entails is that we will take the case and then send it to an outside clinician who looks at all of the medical evidence and then decides whether or not the insurer's decision is justified.
What if it's just pending, though? I'm just wondering if it's not denied or approved in 48 hours. What happens then?
I believe that once the payers have all of the information under our law, they have to make a determination on whether to approve or deny the request within 48 hours. And not to spoil some of my colleagues' testimony, but I believe that they will tell you that most of the time when PA requests take a while to go through, it is because additional information was requested, and it takes a little bit of time to gather that information and send it along.
Art, you had a follow-up question?
Yeah, I just kind of following up on it. What's the protocol for the patient's appeal? Does the patient even know?
Yeah.
How is that communicated to them? Verbally, via email? I mean.
Yeah, so that's a good question. So what you will receive as an insured is what's called a notice of an adverse benefit determination that says why your claim was denied. And
I will receive that as the patient.
you will receive that. It will say, we reviewed your request for an MRI for this reason, and we are denying it because it is not medically necessary for the treatment of
Yeah.
your condition.
Yeah.
Then it will go on to list your appeal rights and list resources that you can access. So Blue Cross and MVP's notices include information on how to contact a healthcare advocate, for example. What you can do then as a patient is you can file a first level appeal. And if that is also denied, then depending on what kind of plan you have, you can either take a second level appeal or file for an external review with the department.
And does the provider play a role in this at all?
Yes, providers do play a role in this. Because providers are the clinical experts
Yeah.
here, they will often pursue appeals on behalf of their patients.
Okay, good. Thank you. Don't get the weeds on that. Yeah.
Okay, so really quickly, I want to talk about the information we have about prior auth requests and how many of those are approved, because this is about the hardest data we have on how PA works in Vermont, at least in terms of approvals and denials, which again is not necessarily timeframes, and in that sense doesn't capture the agita that providers face when they're on the phone trying to get these approved on behalf of their patients. This is an example for Blue Cross Blue Shield of Vermont's 2021 Act 152 filings. And we're just going to focus on medical PAs for the sake of simplicity. For medical services, there were 18,931 PA requests, of which 7.2% were denied. Of those, 20 were appealed, and of those 20 that were appealed, one was appealed to the next level of review within Blue Cross Blue Shield. So what our data from the Act 152 filings show in general is that for the most part, the vast majority of PA requests are approved. And all of that data is available on the DFR website under the insurance reports section.
So I just want to clarify what this is telling us. So a vast majority are approved, but this is not telling us how much effort and time was taken to get that approval.
Exactly.
Thank you.
So as part of the Act 183 report, the department, along with the Green Mountain Care Board, looked at actions that other states had taken to streamline the prior auth process in those states. And we identified 4 different areas that the department, or that the state of Vermont could look at in terms of streamlining the process. But before I get to that, I want to just stop on this slide because I feel like it's really important, especially in light of the previous testimony about how the PA process is like a game. And I feel like that needs a little bit of amending because it's not just a game, it's a dozen games, all of them with different rules. And I think that's one of the more frustrating parts for providers. So I just want to stop here to talk about which parts of all of these games that the Department of Financial Regulation has authority over. So this is the payer breakdown writ large in the state of Vermont. So there's a small slice of uninsured folks, and between Medicare, Medicaid, and employer-sponsored insurance plans that are generally regulated by the federal government, that takes up about 80 to 75% of the total market in Vermont, leaving everything that is within the department's purview, which is the individual, small group, and large group markets, with just a very small slice of this pot. We're just looking at these two little slices.
Can I get clarification from Ledge Council? So you only have control over that small slice.
Yeah.
But if we pass legislation for a prior auth process, would other insurance companies who have Vermont members have to follow these prior auth processes? So like, let's say I had Cigna and I go and to the doctor, would Cigna have to follow these processes?
Jennifer Garvey, Legislative Council, I think they're included in the slice that DFR regulates.
Are you asking about like ERISA
Are
plans?
you asking about self-funded plans?
I'm asking right, so self-funded, no.
Self-funded to the extent of the self-funded plans, no. You can have insurers who are regulated by DFR for their fully insured commercial plans, but are not subject to DFR regulation for their self-funded plans.
Okay.
And the same logic would apply to there are providers in like Southern Vermont that see a lot of patients who have like Harvard Pilgrim, for example, because those plans are regulated in Massachusetts, they would follow Massachusetts law.
Okay.
They're domiciled in Massachusetts.
So this won't help everyone,
Yes.
basically what we're saying. Okay, which is,
Lori, could we clarify that point? I missed a little bit about, so are we saying that the small
small
employer,
employer and individual
Yes.
employers is what we control.
okay, so this bill is only about that,
Right.
okay?
Right. Which is most of what we can, I mean, that's usually what we always.
Right, oh, I know, yeah.
So we just want to make sure that we're not saying, you know, if we do something here that, you know, everyone is going to fall under it and that, you know, everyone's going to feel happier about prior. auth.
Okay, so if we pass this bill, then we're affecting that, but everybody else will stay the same.
Yes.
Okay, all right,
Let's
right,
just say we don't have control over whether or not they stay the same.
right.
We choose to follow.
No, I understand. Okay, thank you.
So, hold on, Sebastian. We have Brian and then Alyssa. Brian, who is now on Zoom.
Yeah, I wanted to, I don't expect an answer right now, but I'm wondering if at some point we could look at specific numbers of lives that would be impacted by this decision, you know, in terms of like, yeah, thank you.
Yep, we can. Alyssa?
I just wondered, does everybody have to use the uniform prior authorization form, the standardized one?
Yeah, that is only commercial payers that are regulated by the department. So
So self-funded don't have to use that?
yeah, self-fundeds don't have to use that. So it is Blue Cross Blue Shield of Vermont, MVP Healthcare, Cigna, and Vermont Medicaid. And it's one of the rare instances in statute where the commercial insurers have to be on the same page as Medicaid.
I thought the form wasn't mandated. Is that the form we're talking about? I apologize.
They have to accept it, but it's not,
Okay.
it's not mandated that they use it for everything.
Okay, got it. Leslie?
Would we be able to have a conversation with Diva to ask them to do?
Yes, we will have Diva at the table.
So that'll expand its reach. we have that opportunity.
We have the opportunity, yes, but they operate separately, so we'd have to hear from them on
Yeah, I
how
get
they,
that, but we could, as I'm saying, we do this, but then we can also do that and
if
expand.
it's needed, yes.
Yeah.
Okay. Thanks, Sebastian. Oh, sorry, one more
I'm
question.
sorry. Do you know, not Medicare Advantage, but do you know if Medicare has any requirements for prior authorization? Just traditional Medicare?
Original Medicare, generally, does not, but, we are seeing a big shift in the market right now as people move from original Medicare with MedSup to Medicare Advantage plans that do have, PA requirements.
We don't control those.
Right.
Okay.
Okay, so where we left things last year was that we had identified what other states had done to ease the PA process in different stages of the timeline. And what we had identified was things like expanding gold carding, limiting how insurers apply step therapy protocols, decreasing the timeframes for review of PA requests, and prohibiting reauthorization, or expanding the timeline of authorization is maybe a better way to put that. So over the summer, I worked with Julia Bowles at the Green Mountain Care Board to conduct a working group where we met with different stakeholders to discuss these reforms that had been implemented in other states and like take the temperature of everyone involved and see where everyone stood. And the results of that working group are in the memo that we shared with the committee. So I'm not going to belabor those points here, but I did want to touch upon some of the provisions of the bill, if you'd like, since I only have 10 minutes left.
That would be great.
In general, the department is neutral on this bill. However, we did want to note that there are components of this bill, especially with respect to approving claims edits and setting the rules for gold carding that we feel are outside of our institutional expertise because none of us are clinicians. I'm really flattered that you think so highly of me.
Whiteboard can do it all.
Yes. But I actually did not go to medical school or have a residency or any of that stuff. And no one at PFR has that kind of experience either. So we are not the right kind of agency to do that kind of work that really gets into the clinical weeds.
And so for the prior auth section, we're specifically talking about section 4 on page 12, which says Department of Financial Regulation shall adopt rules, bulletins, or other guidance that prohibits carriers from imposing prior auths for any generic medication that have a whole lot of other stuff that have low variation across healthcare providers and denial rates of less than 10%. Is that the section you're referring
Yes.
to? Okay. And do you have a suggestion on who would be the proper authority to do that?
We don't. There are other agencies in state government that maybe do, but I don't want to put anyone on the spot.
Yeah, I got it. What is, does DFR have a role today, other than not other than, because it's a very important role, the attestation and the convening that you did all summer, which thank
Yeah.
you, that was great. Do you have a role in prior authorizations today?
Our role in prior authorization is really at the end of the process today, where we oversee the external appeals process. But even then, we oversee the process, but we don't make the decisions. That we rely on outside physicians to help us do that.
Okay. Okay. And otherwise you're neutral on the whole bill, or is that your statement for the whole bill or just prior authorizations?
The whole bill.
Okay. Okay. Any questions for Sebastian? Okay, great. Thank you.
Thank you.
Thank you.
Okay, so I'm gonna look at my team here. And Emily is on the list, but she's just was on here in case we needed her, right? Sebastian, she's not. Oh, she's here. Hi. I didn't know you were in the room. So you don't need to testify. Okay, great. So, and Kelly,
Is on her way. I'm here.
she's here.
I'm here. I'm just short, so you couldn't see.
No, I saw you. I saw you come in.
My glasses. It's okay.
So you have until 12 or no?
I can go till 12, yeah.
Okay, so let's stick with the order here a little bit. So Julia, did you come on up? So Julia's health policy advisor with the Green Mountain Care Board.
Good morning. I'm Julia Bowles. I'm a health policy advisor at the Green Mountain Care Board. Covered my introduction for me. So Sebastian covered some of the areas that I've worked with him on. But I guess to start off, I just wanted to sort of say at a high level, the board has worked on prior auth over the years in very much a policy capacity as opposed to through our regulatory work. Going back a decade now, there were the prior auth pilot programs that we worked on, and those were kind of the precursor to the gold carding work, which now there's reporting on today. And over the last couple of years, we've done reports through the Act 140 report and then the Act 183 report. So we've touched prior auth in that capacity. And then I also staff our primary care advisory group, which was originally an advisory group created by the legislature that we've continued to have a direct interface with primary care providers. And prior auth comes up literally at every primary care advisory meeting I personally have ever been to, whether it's on the agenda or not, because it is such a big administrative burden, as you've been hearing about. So I just wanted to kind of set that stage that we've really touched prior auth in the ways that we hear it sort of bubble up in our work about access, about when we're thinking about provider burnout, administrative burden, those areas. It's not something we don't get in the weeds in the way that DFR does from a regulatory standpoint. Also, just to mention, prior to coming to the Green Mountain Care Board, used to work at a national nonprofit where I was working on this issue with in a patient advocacy capacity. So I've spent just a lot of time talking to folks. So that's separately where some of my knowledge about this comes from, but again, not from my work at the board. So let me just glance at my notes to make sure I'm covering what I wanted to say. So as it relates to this bill, as Sebastian covered, the Act 183 report directed DFR and the Green Mountain Care Board to look at opportunities that the state could take on prior authorization. We sort of analyzed what other states have done, and many of those recommendations have become what you see in this bill today. So at a high level, the board, because we hear so much about administrative burden, are sort of conceptually supportive of areas that the legislature, like actions the legislature can take to reduce administrative burden. But we really haven't gone into the weeds of like the bill as it is today. I think that role is better served by everyone else you're hearing from. So that's sort of my comments on the bill. And then I just wanted to take a moment too to talk about the ways that we hear about prior authorization in our work, because like I said, it just comes up in a lot of different places. And I think everything I'm going to say is essentially a high level summary of what the experts that you're having testify will go into in a much deeper capacity. But first, the primary care advisory group, like I said, I staff that group. We actually had a meeting last night where the mention of the testimony today was coming up, and they had a flurry of comments and stories and said, you know, like, this is such a huge issue, as you've been hearing and will hear from other providers. But even going back to 2018, the primary care advisory group adopted a position on prior authorization, and I testified about it last year. It's in the slide deck Sebastian was just sharing, but the summary is that they recommend eliminating prior authorizations for primary care providers because of the administrative burden challenges, the delays in care, and the sort of not knowing, like the game we've been talking about, not knowing what boxes to check, and that ultimately they end up getting the care for their patients at the end of the day. It's just how long does it take and how much work does it take? So the primary care advisory group members have plenty of stories. I know many of them have shared them at our public meetings over the years. They've emailed them to me. I know they'd be happy to come in and talk if you're taking testimony on this in future days, or if you want them to send in notes, but it is a constant topic of conversation. Also, last spring, the Green Mountain Care Board held a roundtable about primary care to just hear from primary care providers about what issues they're facing as it relates to sort of their sustainability and burnout and the access challenges that we hear about. And the board doesn't directly regulate primary care unless it's via some of our other processes, like if they're hospital owned or something like that. But we know that the decisions we make have impacts on primary care providers. And it's just, you know, preventative care helps keep people out of those more expensive settings. But all of that to say, despite sort of all of the many other topics that could come up at that type of meeting, administrative burden and prior authorization was hit on by many of the speakers. As a thing that, like, if we, the state, could do something about it, that would greatly improve folks' ability to keep practicing, to have more time with patients. And then most recently, this committee in your joint session last week with Senate Health and Welfare heard from Chair Foster and my colleague Marissa Melamed about our Act 167 community engagement work. And in those meetings, particularly the provider-focused ones, we also heard about prior authorization. Dr. Bruce Hammery, who's the consultant facilitating those meetings, he presented at the Green Mountain Care Board meeting yesterday afternoon. I'm happy to send the recording and the link to the slides. And it's really great. He summarizes a lot of the different themes that were emerging from those meetings, but I wanted to read two of the quotes that he had about prior authorization that came directly from physicians at the meetings. And it was on a slide that was about primary care and under a section on administrative complexities. And the first quote is, "I spend at least 2 hours a day on the phone for pre-certifications and prior authorization." Short and sweet, but I think it really, you know, if you add up 2 hours a day times 5 days a week, times 52 weeks a year, times all the providers that we have that are dealing with these issues, that's a lot of time on the phone, you know, writing emails, accidentally hanging up the phone, as we heard earlier today, but, you know, just the burden that comes with that volume. And the second quote was that our office has 4 support staff for each clinician. This comment wasn't necessarily said directly in connection with prior auth, but I think that's just a thing to think about as we think about the administrative burden that this is placing and hearing practices having to hire staff and build all of that time in just to deal with these topics. And that same slide talks about primary care provider shortages we have in the state and the burnout being one of the reasons that providers in these meetings were citing. So I think all of that to say, we at the Green Mountain Care Board hear about this issue as it sort of permeates our system and impacts other issues like these high level goals of access and affordability and quality that we're all trying to work on. Yeah, so I think that kind of sums up what I was planning to cover. I would be happy to connect the committee with the primary care providers that I work with who are incredibly passionate about this issue. But
So I will say we've had a lot of people send in written testimony, so I'm going to continue to encourage written testimony. We'll, after we hear, you know, from today, we'll have a further conversation about whether or not we need to hear more directly, but I encourage written testimony on all sides. So I'm going to ask a question that you may not be able to answer today, but we just heard from Sebastian at DFR that they would be unable, and I'm going to talk only about the prior auth section right now. They would be unable to, the section 4, to do the work. Would Green Mountain Care Board be able to be the agency that does this work? of determining which services could be eliminated, which prior authorizations could be eliminated based on variation that have low variation across healthcare providers and denial rates of less than 10% across carriers. And you can come back.
Yeah, thanks for the question. I mean, like I said, we don't deal in insurance plan policies at that level. We have our rate review process where we're looking at the premium, but I think all of the other, DFR tends to be the place we go for that type of expertise. So off the top of my head, that's not an expertise that we currently have.
Okay. Any questions for Julia, Green Mountain Care Board? Great, thank you so much. Okay, let's go to Kelly. And then we'll go to the insurance companies.
Good morning.
Morning.
Didn't get a chance to print out my testimony, so if you don't mind.
No worries.
I have my notes here. Again, Kelly Lang, Vice President of Contracting for the University of Vermont Health Network. I gave my bio last week. And I did actually, in my testimony, I submitted to Claire, reference that prior testimony because again, shows some of the manual work that is repetitive here. So I didn't want to go through it again for your attention. But I want to just again, provide education and details and then answer any questions about the legislation or process at the hospital level. I will note, again, we have primary care, multi-specialty clinics, inpatient and outpatient. So everything you heard about primary care does impact our clinics, even though we are a health system. The clinics still have independent staff and face the same struggles. As we have come across as a health network, we centralize where we can, but again, that still takes time and it doesn't mean drastic efficiencies right away. And the final system component is, as you may recall, we just deployed Epic, may or may not know this. So it's our health records system. And that is now across our system, which does gain efficiencies. But again, that's just being implemented and that does not, again, solve an automated process for this. So we are attempting to streamline processes, but still struggling. The same policy analyst that I spoke about last week pulled some fabulous numbers in addition to the 2,000-ish payment policies a year. We're estimating 1,900 PA changes during the year.
How many?
1,900. That's an estimate based on number of codes per week extrapolated out, and it's in the testimony. So this is on top of what we did speak about. And it does get down to the code level, as you've heard, or so one CAT scan may not require it, but another may. So when we have to go through these notices, it's very detailed. And so when we say changes, it could be at that specific level. The changes also do come in various ways, just like payment policies, and are made at random times during the month, during the year. There's no consistent process. And I think the message here is consistency. Contrary to belief, I'm not here to testify that all prior auths should go away. I just want to be clear. There can be appropriate times for safety, most importantly, of a patient, that they may be appropriate. To Sebastian's point, that's clinical related. But I just want to be clear, this is about how we right-size the system and really about consistency in reporting, much like the payment policies, timing, when payers can do it. And even though there's no controls, if you can say, over self-funded, a lot of self-funded do follow the commercial plans. So Sebastian was clear, there's no regulatory oversight, but very often the self-funded plans will follow. So if we make some consistency across the system, you will get that effect the most part. With the current PA process, as we review them to the best we can, and we have notices in SharePoint and electronic, it is still manual. The clinics and the staff have to go in and look at the payer portals. We provide as much streamline, but because they can change daily, if something didn't have a PA yesterday, it might today. And so the staff is also hesitant, and we talked about gold carding, and I worked on that when I was at Blue Cross. And in theory, it's a great idea. But if it's not applied across all of Blue Cross, so Blue Cross may do it for a large, or MVP or Cigna for a large portion of their population. But if it's not for all, you have people who are concerned that their job saying, well, what if I miss something? I need to go check. So they're actually doing work for a PA that is not necessary. And so that's again frustration at the clinic level from everyone doing the PAs to the provider, who then is being questioned, why are we writing off all these dollars? And, you know, they thought it was technically necessary. So the process that, again, we're looking at does cover the wide arrays. Pharmacy is a large PA change process. And I say pharmacy, infusions, retail pharmacy do impact the hospitals because we do have both. Durable medical equipment, when people especially, you know, have to leave the hospital with some sort of device, that requires a lot. And again, we have them in terms of, we say PAs, some of that is also prior authorization for inpatient review and processes. So what is the appropriate level of care? All this work, this is a high level estimate based on wonderful manager, but she doesn't want to be held to exact, is approximately 76 people through our 3 hospitals
That are working on prior auths.
that are working on prior auths. And that does not include clinicians who are doing peer-to-peers. So if we appeal, that's now the provider, sometimes a nurse practitioner, again, clinician across the system. And that does not include that area of level of care, that utilization management for more the inpatient. So that's staff submitting PAs and working through, and it could be a level of administrative or clinical staff, again, pulling together the information. So we're over $2 million in staffing. I would actually say that's really understated, but I, you know, wanted to note that. We are pulling numbers on PAs to give you scale, but I will say, because the Epic transition, they're not great numbers. And I feel, you know, we're not capturing the way denials are sometimes denied the first round, but you actually may appeal and get them approved. And we are seeing that for at least our labs and diagnostic, out of 38,000 labs that we captured in Epic at the medical center, we had a 99% approval, and this was radiology. So again, but I want to caveat, that's with data with our Epic transition that I would put guidance towards, but I don't want to hold anyone. The payers do have the data on prior auth, so you know that I know, and that's what they're paid to capture and look at. We're paid to get revenue. So it's, you know, the denials are looked at differently. The other components, just noting that, you know, our write-offs for prior auths is approximately $3 to $4 million a quarter. And that means what we're taking, and that doesn't go to the patient. So that's, you know, if we did the service. And some of the problems come, and I think it was somewhat mentioned in the last 2, is when we're changing services during, you know, someone CAT scan or something gets changed to with contrast. Now, some payers don't require a new PA. So I don't want to put that across the board.
So can we just, I want to make sure
Sorry.
people understand this. So you can have a CAT scan, right? Or you might need a CAT scan with contrast, which means you drink this horrible stuff so that the CAT scan, I guess, picks better.
You go in the dark.
You glow in the dark, basically. So there's 2 different processes there potentially for a CAT scan. So go ahead.
So if I get a prior auth or a CAT scan, and then during that time or within the 24 hours, the provider said, no, I need to see it better. So you need to drink the yucky stuff and not have you come back.
Mm-hmm.
Some payers, not across the gamut, so I don't want to put everyone in that category, will require a separate prior auth. Some payers allow you to get that afterwards, but it's a short time frame.
Mm-hmm.
And we should say, and I will say, I have challenged internally to say, well, why can't we just automate it and do it?
Mm-hmm.
And again, it's part of it, the trust factor. And we have certainly areas to improve on processes, but you need the timing and resources and tools. And if we can do it, not everyone can, and it's expensive. We see how much, you know, electronic medical record implementation is. So any change is also expensive. So, you know, some of the things that I've talked with the staff that's on the ground, and that's part of this legislation, is, you know, having that time for retro, if there is. The low volume denial, it can't be just a gold card at one provider. You know, there has to be more streamlining, and at the very least, putting some consistency on how payers are notifying and providing access. I mentioned the self-insure. The other note I want to make important, and Sebastian's very good point, that people are moving to Medicare Advantage, and of which this state does not regulate. This is now at the federal level to what you followed. Rule was just finalized recently by Medicare Advantage, requiring Medicare Advantage payers to create a real electronic system. Each payer has something. This is meant to be very more user-friendly on the provider side. It's requiring 72-hour for urgent cases, which I'll come back to that, and 7 days for non-urgent. And it's requiring a lot more reporting of the MA payers to say why they're denying, because sometimes the denials are not clear. So it's really putting more uniformity into the Medicare Advantage world. So even though, again, we can't control it here, where sometimes it does, CMS does not always do things the easiest, but in this case, CMS has very few prior auths, and their system is fairly transparent, and the staff knows it, which that's the biggest thing. Within the urgent review, I will say 72, and where this bill has 24, 72 is still not enough. I will say, talking to some of the providers, they're just like, urgent isn't 72. Urgent is now at the very least 24. So I just say, well, MA made that change. It's often, at least if we don't have that, there needs to be some retro. But again, that's still a lot of work. So how do we simplify? And the final, point to call out, where we all want a more efficient and better health system. We're using nurses both at the payer side and our side that are not in the workforce. That could be teaching or providing care, are reviewing. And so this does lead to a workforce issue. And it does lead to frustration from anywhere from our billers who are saying, why are we not getting paid for this? And sometimes it's a late PA. And if we can create efficiencies on both sides, it would save, I think, the payers money as well. High level, happy to go any further.
Ellen, and this may not be the right time for the question, so I'm fine if we table it, but when I heard you say 72 hours, but the best case in practice coming from physicians and people who are providing care is now, or at the very most 24, why does it get set at 72? Is that because of administrative costs and time and like?
Oh, at the Medicare level?
Yeah, I'm just curious.
We can answer.
Yeah.
I mean, it's that's the federal.
I just wonder what,
or why, whatever, they go through a process, they go through, we have no idea what that
that's
is.
why that is, care is saying we need an hour at least in 24. Okay, thank you. I just want to.
I think it's the same thing we have to do here, which is a balance between care and a balance between costs.
Okay.
Right. So do you feel this bill as written would help alleviate some of the problems you're having and drive down your costs?
I think it would help. I think the real efficiency, especially the turnaround time, that would help the 20, but I think the real efficiency that go farther and gets to, moving towards a standardization following a CMS or other approach in terms of the payers. I think, again, watch what you wish for. Sometimes CMS we don't like. So I do put that, we have to look as a system, but standardization and rationalization is really the most. So I would take a further look at that.
Okay. I wanted to sort of highlight something that you had said, which I've been thinking about. And I think might have been in Sebastian's slides. So I think right now, if you're under one care, isn't there an exception to not having to get a prior auth on attributed lives? I think that was something that they put in to make it more palatable. Does UVM Health Network, do they take that into consideration when they are actually getting prior auths, or do you not have any knowledge, so you just go through the process anyways? Because I think you said something.
You don't have any knowledge that they're attributed.
Yes, you have no knowledge that they're attributed, so you just start the process.
Yes, it's complicated. We do have an app. So OneCare does provide us information, and this is for Medicaid, so it's not for Medicare. And we do our best to take advantage of that. I think, again, because how the information gets into Epic of an attributed life, it doesn't always get to the staff. There is some mapping, if you will, that we do get some efficiencies. I think there needs to be more process improvement. And again, if it's limited to part of Medicaid and not all our Medicaid patients are attributed, a staff member is going to be hesitant because they don't want to miss What could be very expensive if we don't get a prior auth.
I think I wanted to make a point of the importance of, you know, if we are going to do this, that we have to make it for broad categories. Because, you know, like you just can't make it at the claim, the CPT level. It's got to be for a broad category so that people can entrust that, yes, I know this does not need a prior auth.
And I would add to that in broad categories of a hospital or at a, not at this surgeon at Porter is excluded, or this primary care doctor at this clinic. You just can't administratively manage that. So I would say it needs to be looked at in the larger systemness.
Any questions for Kelly? And I just want to confirm the number you said, it was about 3 or 4 million a quarter for write-offs on prior auths, a quarter. Okay. Great. Thank you. I think what we'll do is take a 10-minute break. So be back here at 5 of 11, and then we'll start with Blue Cross Blue Shield MVP. And we do have Diva. I apologize. I forgot we had Diva on the invited.